Hello, everybody. Good evening, all ICS member, all friends from ICS. First of all, you are welcome to ICS Live. This event is a part of a series of live content prepared by the ICS. You can see the other live events scheduled on the ICS website. And we invite you to be part of the discussion today by adding your comments to the section below in the website. And also please to confirm, and we read and respond to the question as they come in. If there are a lot, we will respond also after the session. We are also pleased to confirm that last minute you have European CME, so you can claim 1 European CME credits, which can be easily converted to your local accrediting organization. And there are more details on how to claim the CME and get your certificate below on the ICS site. So now we can start with this session about the patient dilemma and fears for COVID, but at the same time, our patients have also fear for bladder complication. I am pleased to share with a different position. So we have online Pierre from Paris. Hello, Pierre, everything okay?
Hello, everybody.
Yes, and at the same time from Milano, we have Michele Spinelli.
Hello.
And Gianluca Sampogna. Hello, Michele. What about Milano? Is it okay? Can you say something?
At the moment, okay.
Okay.
After a dramatic situation, we are restoring a good situation.
Okay, so thank you to be here, and we can go on with our presentation. And here you can see the agenda. So first, we have just a little bit focus on the situation in our different hospital and also different country in Paris with Pierre and in Milano, that was maybe the city more interested by this pandemic. And after Denis will speak about all neurological condition and all problems they have during COVID, and now that we are going, we hope so, out of a lockdown. And then I will present just a clinical case about spinal cord that we have just a beginning of this endemic problem. And then we have also Stefania Musco that is here in the room. We'll see just in a few minutes here about some guideline triage that is very useful to use during this phenomenon that is the COVID period. And then Michele will report some data about their experience with using telemedicine, and Gianluca will present a new model of telemedicine that they used during this period. So we can go on with some, here are my disclosure, you can have a look. And this was our situation. As you see in the graph, we had a lot of death in the period between March and the 1st of April. But if you compare that, but also people with COVID in that period, the incidence of COVID was a great number in Tuscany, but was really many less people than in Lombardy. So we have about less than 1 per 10,000 inhabitants. Instead of in Lombardy, they were about 88 per 10,000 inhabitants. So what do we do in our in our hospital? In the spinal unit, there was a strict access protocol, and so no visitors for inpatient, neuro-urologist involved in spinal unit care and the internal consultancy, and new case coming. There were few cases really from other hospital need a swab before to have admission, and after admission they stay under isolation for 2 weeks to be sure that they were not positive. About neuro-urology, the world was closed, and we had just one nurse for the neuro-urology ambulatory. The urodynamic was open, but only for inpatient and not for outpatient. And we did a lot, by more than 100 phone visits, waiting for the institutional activation of teleconsultation website and platform. So in that period, we just changed some catheter, suprapubic catheter, and also some cases with the first stage of sacral neuromodulation that we remove for that period. Now that we are going out, as you can see, from March now to the beginning of May, there are a little few cases, and this is a great hope that we are out from COVID emergency. Also, if we are afraid about a second wave of emergency for COVID. So now we reopen a lot of activity, the outpatient both for the first visit and the follow-up. At the same time, we are still using phone visit, but also, as you see here, now we have a system from our hospital for institutional televisit with CAM and also with some tool to have to do also a teleconsult of the examination. At the same time, we started again with the video and the urodynamic, and we scheduled all examination, all appointment to decide a new priority list. So we prefer before to call, for example, people with high risk dyskinesia and postpone examination that were just checked in more clinical, quiet situation. At the moment, we had only half-day surgery once a week, but with 6-7 hours of surgery, we had the way to satisfy a lot of requests, some situation with heart complication, lithiasis, or but we did also a lot of botulinum toxin, and so now at the end of July we are about to satisfy at least 200 patients. Okay, this is what we are doing, what we have done in Florence. So Milano, the word, please go on with your presentation, Michele.
Okay. Good afternoon from Milan. You know, thank you, Giulio, to involve us in this ICS webinar. And as you said, the Milan and Lombardy region had a dramatic situation during the
Michele, no good sign.
COVID pandemic. It's okay? During the pandemic, in our hospital, we had more than 1,000 patients with COVID, but in the same time, Niguarda remained the hub for trauma, for major trauma, for neurosurgery, and for stroke. And you see the data. And this, you can imagine that is related also for the activity of the spinal unit. In the same time, Niguarda continue with the activity in oncological patients, in deliveries, and in organ transplantation. What happened in spinal unit? Very early in the end of February, we started with a very strict access protocol. we stopped completely to receive visitors. In that moment, we have 32 inpatients and 21 were tetraplegic with a frail situation with patients under ventilations. And so we decide to start very early, despite of the rules that we had. The medical staff worked only in the spinal unit. Some people from our spinal unit give support and went to work in COVID department because the situation was very critical. We had also the risk in a few days in the mean of the pandemic to close the spinal unit, really, because they need a lot of ventilators. We received a lot of new cases from the trauma team, not only people with spinal trauma, because we had to give help to the other department. And we receive also, in the end, 3 patients that have spinal cord dysfunction COVID-related. That is very interesting. As you said in your center, we maintain an isolation of patients for 2 weeks when they arrived in the spinal unit. And one of the problems was how to treat the big number of outpatients. And this is the reason why we start to think in the middle of April how to work with telemedicine. And I am happy that we had the occasion later to show you the process that we did and the results that we have had until now.
Okay, thank you, Michele. Now I think I can call Pierre. Pierre, are you ready? I can't hear you, just the phone. Put on the phone, please. Pierre, open your phone.
Yes, yes, it's okay. I was working with PowerPoint to try to have my slides in the same time. So unfortunately, there is no 2 buttons to do the same thing. So hi, everybody, and good afternoon. And thank you, Giulio, and all the colleagues from Italy to share with us the experience of COVID in my institution and some slides about neurological disease and COVID. So Paris was one of the area which was the most affected by the COVID in France. In fact, there was 2 major regions in the east side of France and in Paris. And we had a lot of patients to face with COVID in my institution, which is a group of 29 hospitals in Paris. We have to multiplicate the number of intensive care beds by 4, but at the beginning of the pandemic, we were faced to a very difficult situation in public hospitals with less nurses than we need. So it was a very, very difficult situation to face this pandemic, which begins early February. But in fact, all medical records and the serology that we can do now show that the first case came in France at the beginning of October in my institution with atypical pneumonia. So it's a long story, and I cross my finger that there is no second wave. The end of confinement or the lockdown was the 11th of May. And during this time, we were faced of 2 major issues. One is the number of patients with COVID that we have to treat. And the second one, which is probably something very important related to neurological patients, is that there was a very strong reduction in the access to care. For example, 85 decrease for access to speech therapist, 40% decrease for physiotherapy, 60% decrease for specialists in France globally. So I'm sure that one of the difficulties that we have now is to treat those patients who didn't have access to specialists during this time. It was a long time. In my institution, we had to more than triple the number of intensive care beds dedicated only to the COVID patients. And in my department, in my neuro-urology department, when we compare that we did the past year, during the crisis, we had to reduce strongly the number of nurses as well as the number of physicians who had to work with patients with COVID in the intensive care units. So we had to cancel all the urodynamics, and different countries, different hospitals, different situation. The choice that we have made is to only have access for patients for botulinum toxin injections if they had the spinal cord injury, to avoid the risk, for example, of autonomic dysreflexia or infectious disease complications. And we did, as all our colleagues, a lot of teleconsultation at this time. So this was a very difficult situation. You know that there was a lot of debate at the beginning of the pandemic. What are the risk factors? At the early beginning of the pandemic, based on the experience from the Chinese colleagues, we knew that the age is one of the most important risk factors, and it was confirmed by the English study, the Open Safely study, which assessed all the patients with COVID-19 in the UK, and they look at the risk factors. Age is the most important, gender as well, because there is more male. But the question is comorbidities. Do patients who have a neurological disease are at most risk of having a severe COVID-19 or at higher risk of mortality? In fact, it's still not very clear, and we were very surprised by the fact that we had very few patients that we regularly follow in our institution with MS or with spinal cord injury, which were hospitalized with severe COVID-19. This is probably due to the fact that the regulation of the ACE2 receptors is probably different, because there is a modification of the regulation in blood pressure. So if there is a lot of things in the literature regarding, for example, MS and COVID-19, very, very few, because there is not real good data with large cohort of patients, well followed, that can give us real scientifically valid information about prevalence, incidence, and risk. I show one, which is probably one of the largest, which was published in the JAMA Neurology, about a cohort of MS in France. And they had more than 300 patients with a positive diagnostic of COVID-19 based on PCR, CT scan, or symptoms. So a group of inclusion criteria. In fact, there is a higher risk of mortality and severe COVID-19 when the patient had a longer history of MS, higher EDSS score, and some clinical characteristic, for example, swallowing disorders. But one of the questions regarding the fact that the COVID-19 is at the same time an inflammatory disease and an infectious disease is related to the treatment that the patient received for their MS. In this cohort, there was nothing which demonstrate that some treatments are at higher risk of developing severe COVID-19. But after this first publication, some more appears, and there was recommendation, for example, from the Italian Society or the British Society regarding the fact that the patient may maintain their treatment. And this is the case, the recommendation all agree that for example, interferon or dimethyl fumarate or fingolimod, there is no higher risk, so the patients still have to use this treatment, but it's less straightforward with ocrelizumab or elemtumizumab, because in this case, there is probably more severe immune depression. And recent studies suggest that those drugs, if they are used for the control of multiple sclerosis, can modify the serology to COVID-19. So serology is inappropriate in this case because the immune response to the virus is probably lower. So for MS, probably more severe patients, more severe COVID, and a specific attention had to be done regarding the treatment they use. You know that from the US, there was some papers in major journals about the risk of stroke and COVID-19. In fact, there is very few scientifically valid information about this. Some papers report more stroke in younger population after the infection with COVID-19. But at the same time, and you can see that on the chart on the left part of the slide, that we were facing less and less stroke hospitalized during the pandemic, the peak of the pandemic. In fact, in Paris, it was 70% less. In the US, in the Cincinnati area, 39% less. Nobody explained why, and we will have more information regarding mortality and cause of death, but this information is not available now. So there is a discussion about the pathophysiology and stroke and COVID-19. This can be due to the pro-thrombotic state during the inflammatory phase of the disease, especially for the patient who are in the intensive care. Also, there was other neurological disease that were described incidentally, for example, encephalomyelitis or Guillain-Barré rather than stroke. So a recent paper in the JAMA from the UK described the different forms of neurological disease during COVID-19 infection. Last group of neurological disease is Parkinson and dementia. Very few papers addressing the risk for those patients, but there is a major confounding factor, which is age and institution, because in France, we were faced to a major pandemic in institutions, especially those for age populations, older population. So that may explain that having those type of neurological progressive disease is probably not a risk factors by itself, it's more by the age. And I think it's all for me. Giulio, I think you have to go with the SCI patient in your institution. I stop to share and you can do by yourself with your slides.
Hello. It was really a nice presentation, also because as an overview for all kind of patient with a neurological disease. And maybe it's surprising that we feel that they were more at risk, but not always is in this way. And the similar is our experience with with a spinal cord injury patient. And so you see here we published this case at the beginning of the drama. It was the early March when also Fauci, in this nice paper published in New England, say we are navigating the uncharted. We didn't know what was going on, and then step by step we understand something. And in this case, we had this tetraplegic man, C4, 56 years old. He was also a hero because he had a shot just defending our prime minister. And he's in a wheelchair since 2013. And during the early rehabilitation, he had a tracheostomy, but now he's in spontaneous respiratory. So now he has a colostomy, and as well he void the bladder by esophageal catheter. Usually he has at least 3 severe UTI a year, so is used, especially when we go and change the suprapubic catheter, to have some days of fever. So they are used to say, okay, you have a UTI very often. And so at the beginning of March, he had some fever. And when he contacted his family doctor, say, okay, is the common UTI that you have very often, and so prescribed some antibiotic therapy and also give the antibiotic based on the last urinoculture. But after a few days, he had always the fever, so they decided to transport him in the emergency department of our hospital. Had no alteration at ultrasound of the abdomen, and what they do was just X-ray of the chest, and they find a little chronic interstitial opacity and some unclear opacity in the lower left lobe. But when they compare with the previous chest X-ray, it was more or less similar. So I was called, it was on Sunday, and I suggest to my colleague in the emergency, as they have no clear symptom, to submit it with a swab, but they decided no, not to use the swab. It was just the beginning. Now we do swab to everyone. So was the cliche, when a spinal cord injury has a fever, the problem 90% of the time is UTI. And so they treated as a UTI with a broad spectrum antibiotic, and then he was moved from the emergency to the internal medicine, where there is one of our best doctor in the hospital, but the same, they didn't take in consideration to submit him with a swab, and so they don't made any change in the therapy, but he was still with the fever, and so they decided to transfer to spinal unit. We decide to isolate him when he arrives, because we had the suspect. And when he arrived, he had again fever, but also a mild dyspnea, nothing else. We repeated the chest X-ray, but it was slightly worsened, nothing more. He had also some hypoxia, so we decided to do a swab, and this was positive. So he had a coronavirus. For this reason, he was transferred to infection ward. And so what we would like to underline that usually these people with the tetraplegia have a limited ability to cough. So the cough is not so clear, and so also other signs that usually are useful for a diagnosis of viral pneumonia. And this is something that we have to take in consideration. And also, after a few days in the infection ward, he was without fever, and so he went at home just after antiviral therapy, and it was really strange because a so critic patient with COVID, we had the idea that he will go to some intensive care. Instead of, he had no problem, and after a few days he solved all clinical problems. So I don't know if it is because they do heparin prophylaxis for thrombophlebitis or for their hormonal status, but in this case, the patient had a good outcome just after 1 week of treatment. Now he's negative, and now he come back to our hospital just to change the suprapubic catheter. So the message is that not always this kind of patient can have signs that are typical for COVID infection, that we have to remove the idea that every time a spinal cord injury has a fever is UTI, but we have to look for something else. And another thing that I'd like to underline was that during the COVID period, we had a dramatic reduction of UTI in our hospital. And it was really a good idea. I don't know if because they have no visit, because we washed a lot of our hands, or because we use mask also during the assistance, but it was interesting. And at the same time, we obviously during the lockdown, we have no spinal unit, spinal injury patient for trauma, but just for infection. So there is something of good during this period that maybe can show some different solution for the future. So thank you for I take my time, and now I leave my place to Stefania Musco. Please, Pierre, if you want to comment and introduce.
Yes, Stefania Musco she's working with Giulio in the same institution, and her topic is about guidelines and triage, which was a critical point in our institution for neuro-urology. Thank you, Stefania.
Thanks a lot, Pierre. So this is a critical issue that actually it was already discussed in previous webinars on the ICS Live. And the first one was in the middle of the lockdown at the end of April. And at that time, the only recommendation that we had from the EAU were just to treat in our patient the emergency, such as the blockage of the catheter or the urosepsis or kidney failure. And that was it. Sorry. Which the camera, yeah. Yes. And then the successful of this webinar was already published on the New, and there were many comments on that. And what is interesting is that the comments reflected the different local situation. And one concern was in particular the need of treatment for high-risk neurogenic bladder and the need, of course, of botulinum toxin A in those patients. So taking into account our local situation compared to the rest of the Europe, whereas the rest of the Europe was at the beginning of the lockdown, in Italy we were into the cage already since months, because we started in the lockdown at the beginning of March. And so our attitude at that time was to understand how to tame the beast rather than having a defensive attitude, because we were conscious that we were not able to kill it. And so the Urodynamic Society, with the Neuro-urological Committee, the Italian Neurodynamic Society, with the endorsement of the International Continence Society, posted a report about a proposal of triage, considering this particular transition period from the lockdown to the normal starting, the starting of the normal activity again. And what is interesting of this priority is that we try to consider the individual risk and the type of neurogenic dysfunctions, so that the timing could be also upgraded at the end of the lockdown, because of the delay of treatment or the long waiting list during the lockdown. And this was this is another proposal of triage. But what is extremely of importance is that there is a wide consensus that the high risk neurogenic bladder should be treated with on a botulinum toxin A within 1 month, whereas in low risk neurogenic bladder, the same treatment can be offered even up to 3 months. But what is not clear from this particular document is the definition of the authors regarding the uncomplicated neurogenic bladder. Because in that case, in that particular case, the priority is put in a low priority level, such as longer than 3 months. So to conclude, it's what COVID has taught to all of us is that the union makes us stronger. So so despite the guidelines and the evidence, the expert opinions right now is extremely important. Thank you. Now it's up to Michele, and I stopped to share the screen, so Michele can start giving us some information about telemedicine.
Oh, thank you, Michele. Now it's your turn about telemedicine. Then we have some questions from Cerebroc and from other people. I think we can discuss at the end. So I see that you are ready, Michele. You can start, please.
I'm ready. Okay, as I said before, in the middle of April, despite the situation, we start to think how to organize something for outpatients, and we start to discuss about the possibility to use telemedicine. And really, I want to thank Gianluca Sampogna, that is the technological doctor that we have, and discussing with this idea, he started very early to organize this service. What is the definition of telemedicine? Telemedicine is a long-distance distribution of health-related services. It could be patient education, remote monitoring, treatment changes, video consultation, or digital transmission of medical imaging. But we know that general data of protection regulation say that all the data concerning health or data concerning a natural person's sex life or sexual orientation shall be prohibited. And so this is the reason why we had not experienced before in using telemedicine. But in the same time, when we start with this idea, we had the help of a very famous professor in the University of Milan, of lawyer, that is an expert of data protection. And so he suggested to us how to build this platform for telemedicine. And we had the possibility of start with this idea because in a situation like COVID pandemic, we had the possibility to start because of the situation. And so we started with this workflow. The workflow started with a phone call to the patients in which we explained the possibility to start with telemedicine. We send an email with the platform and with online questionnaire. We receive from the patient's clinical documentation, and in the end, we have been able to have a medical report for every patient. You see, these are the data of the first 2 months in the activity of neuro-urology and neurogastroenterology. Telemedicine was only for chronic patients. It's impossible to use in first visit or in urgencies. But you see that in the data, in the follow-up of our patients, we use telemedicine around in 90% of patients. What I want to show you, I want to show you that at the end of our triage of the patients, we put also an evaluation survey. And you can see the good feedback that we had for the patients, especially related on the support that they feel with telemedicine, because they had the feeling to be abandoned by the spinal unit. And they said that the communication was easy by phone. They said that our questionnaire was easy to fill in. And especially what is very important is that the patients were not worried to an inappropriate management by telemedicine. They were really satisfied of the service. And I think that is very important that they say that even after the emergency of this pandemic, they would like a prosecution of this service for So I introduced Gianluca, and Gianluca really worked a lot with all the other colleagues of the team at this project, and Gianluca will explain to you in particular what kind of platform we create. Thank you.
Okay, so thanks for the introduction. I'm going to talk about a model for structured online interview in neuro-urology, and I have no conflict of interest to declare. So at the beginning of COVID-19 pandemic, we performed many consultations via phone, but we experienced many problems with each part involved in the process. So we experienced troubles with the connection. Patients were anxious because of a time-limited and blindsided call. They underestimated the important problems like, for example, microhematuria, and they overestimated the minor disturbances. And we also noted doctor-dependent interviews, as in medicine, all medical activities are linked to a specific learning curve. So we decided to build this workflow. As previously explained, we phone our patient, we call our patients, and we ask them for their availability to undergo a telemedicine visit. Later, our patient receive an email where a link for the online questionnaire is reported, and a link for the uploading of clinical documentation is available. At the end, the doctor develops the final medical report basing on the information acquired by the online questionnaire and the sent clinical documentation. The principles behind our online module are the following ones. We have included many questions from international questionnaires validated in our language, Italian, and for self-administration. The online module is delivered by a progressive web app. It means that the link automatically adapts to the patient's devices. And an important principle is pseudonymization. It means that the patient has a code to insert at the beginning of the questionnaire, and the association between the code and the patient is available to only 2 doctors of our unit. Just to have an example, a wonderful example of a question set to include in the online questionnaire for our neuro-urological patient, the mentor tool is a great decision-making tool which can help doctors to define the treatment of our patients affected by neurogenic bowel disease. So if a patient receives a red light, the final result is delivered according to a trophy light system. So if the patient receives a red light, it means that the treatment is inadequate and an immediate change is necessary. While if the patient at the end of the questions based on the mentor tool, if the final result is a green light, the management is appropriate, so the patient can carry on the current treatment. Our online module for neuro-urology is divided into 5 sections. Let's have a look at an example. So we don't have enough time to read all questions, so I'm going to read just some okay, sorry. Can you see it? The online module. Now, are you seeing the? Yeah. Can you see it? Okay. 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 So this is an example of our online questionnaire. It is possible to read all questions for problems related to time, but I'm going to read just some sample questions for each section. The first section asks for general information, like, for example, patient's neurological dysfunction, medicine and allergies. The second section collects information related to COVID-19 emergency, like diagnostic test and specific signs and/or symptoms over the last month. The third section is related to urinary disturbances, and the patient should respond to questions like, have you experienced one of the following signs and/or symptoms since the last visit? For example, blood in the urine, renal colic and/or flank pain, difficulties during catheterization, testicular pain and/or scrotal swelling, and so on. Other questions related to urinary incontinence. The first section is related to bowel disturbances, and it presents the questions inside the mentor tool. For example, how often do you empty your bowel? How much time do you spend each time to empty your bowel? And so on. The final section is very important because it collects the patient's consent to processing of personal data for telemedicine and scientific purposes. Conclusions. We firmly believe that in-person visits are mandatory for first visit and urgency, but telemedicine represents a valid and well-appreciated approach for follow-up, so we are going to carry on our service also after the COVID-19 emergency. And that's all. Okay.
Okay. Thank you, Gianluca. Very nice presentation. I think that this is a nice model. Maybe in the future can be developed. I think that telemedicine is very useful, especially for chronic people, especially thinking about the home hospital. When we will be able to give some assistance at home with the nursing and sometimes with also doctor, maybe is a good tool to maintain a contact with the hospital and follow our patient. So before, I'd like to give you some questions that some of our auditors send us in the website. First of all, I think is a question for Pierre. I think that all of us know very well him, particularly Michele Spinelli, and me too. Is Philip van Kerbroek. Hello, Philip, if you are online. And he asked, how can we explain the significant reduction in serious medical incidents? For example, 70% less stroke in the Paris area. Pierre, can you comment this data?
This is a very good question, and we are doing a study with the Global Health Organization in France, where there is a national registry for deaths, and to look at the mortality and the cause of mortality in patients at home. There is two main reasons: the lockdown that make the patient safer for the risk of strokes. This is one explanation. The second one is that when we looked at the emergency unit as well as the transportation for emergency, they were completely full. And the time to have somebody at phone when you had severe problem, it was more than 2 hours. A lot of patients that we see now, they spontaneously decrease their access to care. This is probably the main explanation, that the patient didn't want to go to the hospital, didn't want to go to the emergencies despite their medical condition. We saw patients, for example, with severe urinary tract complications that stay at home for 2 or 3 weeks despite their severe condition with no access to specialists. This is probably the main reason that we don't have now the clear explanation of this phenomena. And I'm sure that it will be something for the future, that large epidemiological studies focusing on cause of death will show very interesting data. There is not only the cause of death due to COVID-19 infection, but also major population of patients who died during this period of time because the reduction of access to care was crazy.
Yes, thank you. I think the lockdown is similar for spinal cord injury. You have no trauma because the people stay at home. It's strange, but why Usually our emergency is full of people. During lockdown, there was nobody, only the COVID suspect people, not other. I think it was a similar situation also in Milano and in some other city. And another thing was what I said before, that we had a dramatic reduction of UTI in the hospital. I don't know, just before, you can remember, Pierre, we spoke about Escherichia coli pandemia and so on. During this period, all this problem had a reduction. I don't know if it was for the new rule to use in the hospital, that should be normal rule for to be sterilized, to wash hands. Maybe there is no people coming from outside of the hospital. I don't know if you can comment, just a brief comment, and then I have another question for all of you. A comment by Michele.
The comment is that is sure that we had more attention, and so the infection we had before the pandemic was over this infection. So I think that is normal in our department, that in resistance infection we have a sinusoidal attention. You start with rules, after 2 or 3 months you have to restart in a recommendation to nurses, to doctors, and also to visitors. And so this, I think, has been normal in this pandemic. But for you, I want to have a comment. You had really a big risk with your patient number 1. And so it's a good thing that he was one of the patients with a phenotypic or genotypic situation in which COVID was very short, because I remember that in the era of the worst situation in the hospital, every day I wake up thinking, let's hope not to have patients positive inside the spinal unit. And so how did you had an insulation of these patients in the situation in which you found him positive?
No, it was easy. First of all, when we arrived, it was just only one in one room. Okay. And then I transfer him, poor man, in the infection ward for COVID. It was a terrible experience because he can't move, and was in that room where it was allowed only 15 minutes twice a day for help. He can't move anything. And this was a solution. But we had the same experience because we had no COVID patient with in 3 months in our patients that were in the hospital. And as you know, among all Italian spinal units, we had some mail with all, and we had a few cases only in one spinal unit, but no other. So it was a good thing to feel that our patient was safe. But we had also another experience, because when we thought about the title of this session, that was fear for COVID or fear for complication, was that when we started to reopen our activity, for example, botulinum toxin or some examination, we find a lot of patients at beginning, I say during May, now no anymore. They say, no, I prefer no, because they were at the time afraid to come to the hospital. I don't know if in Paris, in Milano, you had the same experience.
Yes, in Paris, we had exactly the same experience, but not so much. We were surprised for that. It was more in other departments and in other units, especially for neuro-urology. We had the same cancellation rate than we had usually, about 10% when we reopened. But we saw patients with very severe condition due to the restriction of access to care. I have just one remark, Giulio, about your patient, because one of the things that we learn, and which was published, is that there is a dissociation between the sensation of dyspnea and the hypoxia. And this is something that is probably very important in our patients with neurological disease, that when we speak with them, it's not only fever, it's also the frequency of the respiratory rate, which is very important. Not only the sensation, because probably of the neurological disease associated with the COVID-19 infection, the sensation of dyspnea disappear despite patients with severe and very severe hypoxia. It's not only cough, it's also this sensation that may disappear as well, which is probably something important for the future, the next wave that we cross fingers with.
I think to the other doctor in the emergency room.
Yes.
Comment related on your question is that it's sure that the success of telemedicine is related on the fear of the patients to come to the hospital, because they, especially in the beginning of May, they've seen the hospital as a very dangerous place where to go. So this experience in my mind is that in the future, and we are working now in
We can't listen you. Okay.
Professional approach. Yeah.
Okay. I have just a last question that is from a friend from Argentina. I know I was born in Argentina, so I feel this friend is Christian Hector Cobreros. He make a question. They know ICS recommendation, but which are the parameters that you use to know when to stop urodynamic assessment and when to start again? I have a simple answer, because usually is my hospital that open or close the hospital to outpatient. So when they give us the permission to study outpatient, we started again to perform urodynamic, and then we give the priority depending on the clinical condition, and this is what our guideline. He asked also about the number of COVID new cases, and at the moment they are very low in Italy. I don't know the exact number, but they are about no more than 50 for a day, 100 for a day. Half are in Lombardy and the other around Italy. If you want a short comment, because you have last minute, 30-second comment from Michele and from Pierre about the last question. Thank you.
So I think that it was easy to close the spinal unit. Is not easy at the moment, the activity, because we maintain really a strictly observation of patients that are incoming. And we have a protocol after telemedicine, patients that come for diagnostic or that come for interventional procedures. They do all the tests for COVID, and they stay a really short time inside the hospital. And you say we are in a good situation in this moment, but we are not so convinced that we are completely out of the pandemic. And so we have still a lot of frail patients inside. We pay a lot of attention.
Same in Florence. Please, Pierre, just a brief comment. We are out of time.
Yes, and the last comment is that the direction of our hospital had to trust physicians, because if it's only a decision from the direction, it's not very well adapted to the situation of the patient. And we were faced with this problem because we missed some nurse in the intensive care unit, and we reopened the urodynamic assessment quite quickly after the end of the lockdown, but we had the chance to maintain the botulinum toxin injections, but we still need to do a triage every day. And it's a collegial discussion with my colleagues to know which patients come, which patients doesn't. So it's still something that we have to discuss with our local organization, but one of the lessons that France learns is that they have to be confident with their physicians in terms of organization, which is probably something very, very important and a good lesson for the future. Let's trust the physicians about the activities which are important and those who are not.
Thank you, Pierre. Thank you, Gianluca. Thank you, Michele. Thank you also to Stefania. I think it was not speaking about ICS system of pathophysiology or new treatment, but this is a real life. I think that we won the first wave of COVID-19. I hope there will be no second wave, but one thing is sure, we are ready for anything and we win any battle. Thank you, everybody. Thank you, ICS, for the opportunity. Bye.
Ciao.
Thank you, good friends.
Bye.
See you soon. Bye-bye.
Bye.